Every time a mistake is made in the NHS, an incident report should be filled out. And every month, 100,000 incident reports are completed. Some of these are things such as letters going to the wrong department, leading to a delay in an outpatient appointment. Whereas others are about patients having medications that they are allergic to, with obvious severe consequences. This is complex, confidential, clinical data. Data that needs interpretation, almost like a chest x-ray, needs to be interpreted by a doctor. And we need to find better solutions. When people say to me, you don't work with big data is people like Facebook or Twitter. But the definition of big data is not just large data sets. It's data that's large, but it also has outstripped conventional means of analysis. And I definitely think we're at that point now in the NHS. But I want to move away from talking about big data to talk about little data. Because I'm sure you'd all agree here that if harm was to come to one baby, that would be one baby too many. But in our analysis of 270,000 incident reports, we found 99 cases of babies receiving a TB vaccination when it was not safe for them to do so. And this could have had potentially severe consequences. We are looking for stories in the data, patterns, signals. How do we find those 99 babies? We have ample data, although we can always do with more. We need to apply clinical knowledge, clinical interpretation, in order to provide us with the information. These are free text responses written by clinicians on the ground. They often need interpretation as to the situation so that they can be better understood. So in order to do this, our research group developed something called the PISA method. The incident reports are read by clinicians who then classify exactly what has happened, such as a wrong vaccine, the wrong dose of medication. They look at what's contributed to that, such as locum staff or being out of hours, and finally the outcome that happened to that patient. We find new concepts and we iterate our framework. And this works quite well. It really is granular enough that we can learn from it, but generalizable enough that we can pick out the patterns in a big data set. But with it comes numerous technical challenges. The coding framework iterates almost daily. This was also an international collaboration. We had researchers from across the world working on this, and keeping my colleagues in Australia up to date when I'm asleep in bed is quite tricky. What we need to do is think about how we can move this forward. We've got over 50,000 patient safety incidents that have been coded by a trained clinician now, of which at least 20% have been double-coded. We've also got our accurate framework, which changes very rarely now, and we've started to develop extra appendices to these for things such as dentistry and other primary care specialities. And what we need to do now is start thinking about automating this process. I don't ever see a world where a computer will be able to completely interpret an incident report. I said before, there's too much interpretation, much like I don't ever see a computer reading a chest x-ray. But what we can do is create algorithms to pick out the important cases, to look for those cases that we need to focus on, that I need to pass on to my clinician colleagues sooner, to find those 99 babies, and to find that needle in the haystack that eludes us. Thank you very much for listening to me this morning. It's been an absolute pleasure.